Please raise your right hand. Do you swear or affirm that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth?
Yes, I do.
Thank you.
Good afternoon. Could you introduce yourself, please?
My name is Nancy Ibos. I'm an LPN at Riverview, Ottawa County Riverview Nursing Home.
Okay. Before we get into the substances stuff, I want to just run through some ground rules of how the process works to make it smoother. Have you had your deposition taken before?
Yes.
Okay. Like this, questions under oath kind of thing?
Mm-hmm.
Okay. When's the last time you had your deposition taken?
Probably 25 years ago.
Okay.
It's been quite a while.
Was it related to...
A car accident.
Okay. And were you... Well, I'll tell you what. Let's just run through the rules.
Okay.
No problem.
I would appreciate it.
Sure. Question and answer. So I'll ask questions and you give the answer to the best of your ability.
Okay.
It's important you say your answer out loud because the court reporter can't take down gestures and things like that.
Okay.
It's important we don't talk over each other, which sometimes I'm guilty of. So if I interrupt you or think you're done and you're not, just let me know you're not done, okay?
Okay.
And I'd ask you do the same if I haven't finished my question yet. Just hold off even though you might know what I'm going to ask, okay?
Okay.
It's important for you to speak up. We have the camera, occasionally we show testimony that way, so we want to make sure everyone can hear you nice and clearly, okay?
Yes.
If you don't understand a question, it's probably because I asked it wrong. So just say, hey, I don't know what you're talking about, or can you say it another way, and I'd be happy to, okay?
Thank you.
If you don't remember something, or you don't know something, don't guess, just tell us that you don't remember or know, okay?
Okay.
And if you want to take a break, I'm going to try not to keep you too long, but it's fine. You don't have to give me a reason. Just say, I want to take a break, and I'd only ask that you finish your answer before you go on break, okay?
Okay.
Do you have any questions about any of that?
No, that sounds good.
Okay. You are, as you just told us, a licensed practical nurse at Riverview Nursing Home, is that right?
Yes.
How long have you worked at Riverview?
About 6 years. In my 6th year.
You were an LPN at Riverview during Jennings Fleenor's time there, correct?
Yes.
You provided some direct care to him, correct?
Correct. For nursing.
Have you had an opportunity in preparation for today to review some of his records?
Yes, I have.
What did you review?
My nurse's notes.
So that would be progress notes?
Progress notes and my neuro checks
Okay.
and my last notes.
Before we get to all that, I want to ask you some basics about nursing home stuff. Can we agree that nursing homes must provide a safe environment for their residents?
Nursing homes do provide safe environments. Our nursing home does.
Okay, and I want to talk specifically about kind of what the rules are for nursing homes, because a lot of people, you know, that on the jury won't have worked in nursing homes or know how it works.
Are you speaking about laws?
No. Are you familiar with the standard of care for nurses in nursing homes?
Yes, I'm sorry.
It's okay. Everyone does it, don't worry. Like literally everyone does it. Is it your opinion that nursing homes need to provide safe environments for residents?
Objection. You can answer.
Yes, I think every nursing home strives to provide that.
And that's an important part of resident safety is to have a safe environment.
Correct.
Nursing homes should provide or use safe equipment when caring for residents. Fair?
Yes, that's fair.
Do you agree that nursing homes should never allow a disabled resident in a shower chair to tip over and fall?
Objective form. You can answer if you can.
I don't think anybody should allow anyone to fall. Allowing them would mean you just stand there and let it go.
Okay, is there a different word I could use to get the same point across? Let me say that. Do you think it's ever appropriate care for a nursing home to have a resident tip over in a shower chair?
No, I don't think that's anybody's goal.
I didn't ask if it's a goal, so I'm talking about kind of minimum standards.
Sure, nobody I don't believe that anybody allows people to fall.
Okay.
That's my answer.
Okay. My question is it ever appropriate care to have a nursing home resident tip over out of a shower chair?
Object to the form.
I don't understand. I'm sorry.
What don't you understand?
Well, it wouldn't be appropriate care. You wouldn't be caring for them if you allowed them to fall.
Okay. Do you agree nursing homes should never use equipment that's unsafe for a resident?
Yes, I agree that we should not use something that is unsafe.
Using equipment that's unsafe for a particular resident can lead to resident injuries. Is that fair?
Objection.
Go ahead.
You can answer if you can. I'm sorry.
Say it again.
Using equipment that's unsafe for residents can lead to resident injury.
Objection.
Broken equipment should not be used. I agree.
Okay, I'm
And-
talking more
and-
broadly than
and
broken.
oh,
I'm saying unsafe. So obviously broken presumably is unsafe, but some things may not be broken but may not be safe for a resident. So my question's about using safe or unsafe equipment. Can we agree that using equipment in resident care that's unsafe for a resident can lead to resident injuries?
Objection.
I don't know.
Okay. Would you use equipment that was unsafe or that you believed was unsafe for a particular resident?
No.
Why not?
Like you said, if I thought it was unsafe, I'm charged with the care of my resident. I would not use something that I thought would hurt them. I would not knowingly do that.
Do you agree that nursing homes like Riverview must provide each resident with adequate supervision to prevent accidents?
Objection. You can answer.
Can you say it again, please?
Sure. Can we agree that nursing homes like Riverview must provide each resident with adequate supervision to prevent accidents?
Objection. You can answer.
Yes, we provide our residents with supervision as needed to prevent accidents.
Okay. And nursing homes should provide every resident with adequate assistive devices to prevent accidents.
Assisted devices
Objection. You can answer if you can.
are assisted devices.
Assistive devices.
Like a cane or a wheelchair, is that
Sure.
what you're thinking of? Yes, we do provide those. They
And-
are helpful for residents.
Nursing homes like Riverview must ensure that resident environment remains as free of accident hazards as possible. Do you agree?
Objection. You can answer.
Yes, we strive for safety.
Nursing homes are required to assess individuals for risk factors for falling and create appropriate plans to prevent the resident from falling. Fair?
It's true that we do that.
Yeah, I don't just mean, and I hope you do, but nursing homes must do that. It's a requirement that they do that. Fair?
Yes, it's in our records.
Okay. Can we agree that falls can be a matter of life and death for residents?
Objection. You can answer.
I've never had anybody die from a fall, but I guess it would be possible.
Do you treat fall prevention in residents seriously? Do you take it seriously?
Yes,
Why?
because I don't want my residents to get hurt. I care about my residents.
And do you understand there can be significant injuries or even death that can result from falls?
Objection. You can answer.
Yes.
I'm going to read you a definition of neglect, and I'm going to ask if you agree or disagree with that definition. Okay?
Certainly.
Neglect is the failure of the facility, its employees, or service providers to provide goods and services to a resident that are necessary to avoid physical harm, pain, mental anguish, or emotional distress. Do you agree with that definition of neglect?
Objection. You can answer.
I would also add knowingly, and yes, I would then.
Okay. Do you believe that a nursing home cannot neglect a resident without intending to neglect them?
Say it again.
Do you believe that a nursing home cannot neglect a resident without intending to neglect?
Objection. You can answer.
With our standards and all the assessments that we do, I would find it hard to know that it, believe that it could be done without purpose.
Okay.
Is the legal sense of that different than what I would feel is just care?
Well, so what I read you as the definition is from the federal regulations, and it doesn't include doing it on purpose. And I appreciate your answer. You feel like it sounds like, if I'm hearing you right, that there ought to be some intent behind it.
Yes.
So my question is, can we agree that nursing home residents can be neglected unintentionally? Say you miss an order, you don't, you
Yes.
thought
I
you
see
fed
what
them, but
mean.
you didn't, those kinds of things.
Yeah, I guess that could happen, yes. All right, then I agree to that definition.
Okay. Nursing homes must supervise residents to ensure they are safe. Fair?
Yes.
I think I already asked you that. I'm
Yeah,
sorry.
I think we have.
I have it twice. Doesn't make a lot of sense.
We'll charge you twice for that.
What do you, aside from what you might have reviewed in the records, I want to ask about your independent memory, if any, of Jennings Fleenor. What do you recall of him?
Well, basically, it's been over 2 years, but two things stick out for me. One is that he was a frail man in the end stage of his diseases. But the other memory I have is more personal. Do you want to hear that?
Yeah, I do.
Okay, it was when we first, when I first started caring for him. He liked to be around people. And so I would bring him to the nurse's station in the hallway, and I noticed many visitors after visitor and residents stopping to say, "Mr. Fleener," and they would shake his hand. And everybody seemed to know him, and I thought, wow, he was really well thought of in the community. Not being from here, I wasn't sure, but it just impressed me. And he couldn't hear what they were saying, but he was always so gracious, shaking their hands and smiling at them and saying, "It was nice to see you." And he couldn't hear a word he was saying. I think he thought he was in a car dealership. But it was just, that's one of my memories of him that touched me.
That's nice. Do you recall when that was? Was that when he first arrived, or when you
Yeah,
first?
it was when we first, it was like within my first couple of weeks of taking
Okay.
care of him.
What else do you remember about him?
Other than my nurse's notes,
One thing I saw throughout is this idea that he was relatively pleasant, kind of a pleasant dementia, pleasant confusion. Is that something you recall being the case?
yeah, at times he could be combative, probably related to discomfort and confusion.
Okay. How should nursing home nurses like yourself respond to those kinds of situations?
Well, it's individualized. Some people you can step back and reapproach, and it's a new day. Sometimes you get a different staff member to approach, a different face.
Yeah.
Makes a big deal. Reassurance, you try different approaches to see what works. You share those findings with your other staff members, so we can all use those tools when we deal with them.
Did you have a regular shift that you, at the facility?
I only work day shift, yes.
Okay. And how often would you be on unit with Mr. Fleenor?
That was my assigned unit.
So you'd see him regularly.
Yeah, we have permanent assignments at our nursing home.
How many days a week were you working in 2016?
3,
Okay. Any particular days?
no,
Not like weekend, weekday type thing?
every other weekend and 2 days during the week.
Got it. How long are the shifts?
12 hours.
Is that still the case today?
Yes, it is.
And when you work those shifts, what, I think it's unit 2
Yes.
that we're talking about?
Mhm.
Okay. What other nursing staff would be working unit 2 on the day shift?
I would have STNAs,
How many?
usually 4, sometimes 3, depending on my census.
Okay, who else? Anyone else?
That was all that was assigned to the hall. I would have a nursing supervisor for the building.
Anyone else?
And activity staff comes and goes.
The therapy folks come and go occasionally as well?
Yes, thank you.
I didn't know if
But
they.
they're not assigned to my floor,
Okay.
per se.
You were telling us a little bit about how the different techniques or strategies to reapproach or re-engage with somebody who's being combative. Was there a particular approach that worked well with Jennings?
I don't recall
Okay.
at this time. I'm sorry.
There's a few spots, and I honestly can't remember if it was your note. I don't think it was, but where they talk about reassuring when he would get tighten up with some care and then would need some verbal reassurance. Do you recall whether that's something that you would engage in with him?
I don't recall specifically with him, but it is something I would easily do with anybody.
What other memories do you have of Mr. Fleenor?
I don't have any other memories.
Can we agree that Jennings Fleenor was a fall risk, someone with a high fall risk?
I would have to look at his notes. We do a risk assessment. There should be a risk assessment. And that is what determines the fall risk for each patient.
Let me give you the real one.
Thank you.
In Exhibit 5. Take a look at that. That's a fall risk assessment for Jennings Fleenor.
Yes, it says high risk.
Does that comport with what you can recall of Mr. Fleenor, that he would have been a fall risk?
Yes, this is the criteria that we use.
Okay. If you looked at this fall assessment, can you see fall assessments in your electronic medical record system?
Yes, I can.
Would you know who performed the assessment based on looking at in the system? Would you be able to tell, I did this one, someone else did that one?
Oh, sometimes, yeah.
Okay. I was just curious, this one doesn't have any kind of name. The ones we got don't have names, but I assume they do in the system.
They probably do.
Okay. Have you ever been unable to identify who completed a particular assessment when you look it up in the system?
I don't know that I've ever attempted to.
Okay. How would it have been communicated to you that Mr. Fleenor was a fall risk? How, as a nurse, as a floor nurse there, how do you learn that about residents?
Well, I can look at the fall risk assessment.
Okay. When you get new residents, how is that communicated? Is there a particular form, or particular way that information like that's communicated to you?
This form is filled out.
Okay.
that you showed me, the fall risk. And with new patients, we have shift-to-shift reports for all of our residents. And with a new patient, you pass on from nurse to nurse, aide to aide, their abilities, so that we all know how to transfer them.
Is that verbal or written or
It's
both?
verbal.
Is there we heard from an aide who mentions, I don't know if this is the right name or not, but a shift change report, a
Yes.
written document?
It's a verbal report that we
Okay.
give.
She was,
Aide to aide gives a verbal report, nurse to nurse gives a report every shift.
she was describing, I don't know if you guys use like cardiac style, but she was describing, you know, by resident with assistance level needs, you know, 2-person, 1-person, that kind of stuff. Are you familiar with a paper type report like that?
Well, the aides use a cheat sheet that they write down
Okay. So that would be like some,
to help their memory.
that wouldn't be a formal,
No.
okay. When residents like Jennings Lenore are resistant to care or combative because of their physical or mental conditions, can we agree that's not something that you should blame the resident for?
Objective form. You can answer.
Why would you? No. You don't blame residents.
So for folks who don't work in long-term care, if someone is combative or rude to them, they might react normally and say, why would that person be that way? How is it different in the long-term care setting in terms of how you react to these residents?
Well, we don't respond in kind when somebody is angry or combative. Our goal is to keep them happy and comfortable, and we just reapproach, and we use just different tools in our repertoire of different approaches. When you get to know a resident, if you know what makes them happy or distracts them, you know, a magazine, picture of their family, you use whatever you can, because the goal isn't to have them agitated.
Okay, is that part of providing care for their conditions when they have a condition like that?
Yes.
Do you agree that documenting care provided to residents in their medical records is important?
Yes.
Why?
For this. It also communicates from one nurse to the next if I've been off a week or if I come into a new hallway.
Excuse me.
I can look back. You know, memory isn't always 100%, so if something happened, you know, well, that looks familiar, did he have that test before? I can look back in the record and we can see that, oh yeah, they did have this and this is what the test results were, or so it is helpful.
Do you agree it's important to resident safety that care be accurately charted in the medical record?
Yes, we all strive to write as accurate as we can because it is a document.
When in your shift do you chart?
It depends on what's going on my shift, what time I have. My residents come first, and then I can always document comes as I can.
Okay. So on a typical shift, does that mean, well, maybe the question would be, how are there terminals set up? Where do you do the documentation?
At my nurse's desk or at my on my medicine card, I have a computer that goes with me as I push the card around.
Okay. And do you do medicine distribution?
Yes, I do.
Are you documenting through that terminal, through that computer on the cart every time you administer medication?
Yes.
And then other than that medication administration, what are the other big duties of what you do on a shift?
Well, I provide treatments when there's wounds. We do dressing changes. We do vital signs and assessments. Some are routine. I make doctor appointments. I update doctors on appointments, changing condition.
If a doctor is, you either need to get an order signed off from a doctor or they contact the facility about putting a new order on, how are those handled? Is it by unit, like you would be the one taking the telephone order, or is there some person who does all of them?
It's by unit.
Okay, so if someone, let's see, who was Jennings' doctor?
Dr. Callahan.
And Dr. Callahan, that's one of the, I think is he the medical director of the facility too?
Yes, he is.
So he's the default doctor that would be assigned to residents who don't have some other primary care doctor they would insist on having. Is that fair?
Say it again.
Is he assigned as the doctor for all residents who don't prefer to have a different doctor?
Then they choose him.
Okay, but he's the default. Does that make sense? If you don't come in with, I want to be with Dr. Jones or Dr. whoever, he's the one that's assigned.
I don't know how that works. That's not on my repertoire of duties, but he does. I know he does take residents who come in, whose doctors, like if somebody comes in for rehab, they don't. Their doctor doesn't follow nursing home patients. He will cover them while they're there.
Okay.
Is that what you mean?
Yeah, and also for long-term care residents, right? Like Jennings Leaner was a long-term care resident. He would pick up residents without a different primary care doctor as well. Is that right?
I would think they would choose.
Okay. How many, unit 2, is that any kind of specialized unit or is it long-term care?
It's generally long-term, but I do provide care for short-term or skilled patients.
And how many residents are there on, I said unit 2, station 2?
Okay.
How many beds?
We can house 36 or 34. 36? I think it's 36.
Do you know at what point it kicks from 3 aides to 4? Like at how many?
No, that's not my decision.
I'm just wondering if you know like what the number is, what the
No.
cutoff is.
No, I do not.
Okay. How many of, in percentage, average percentage is fine, how many of the patients on station 2 are being followed by Dr. Callahan?
I couldn't tell you.
You think more than half?
I don't know.
You're the one who would be taking orders or reaching out to the doctor for orders for your residents?
Yes.
So I figure you spent a lot of time either talking with Dr. Callahan or probably staff of Dr. Callahan with regard to those orders. Is that fair?
What would you need a lot of time?
Well, why don't I just ask you, how many times a day do you think you interact with Dr. Callahan or his staff for patient orders?
Maybe once a week? Twice a week?
All services provided to a resident should be documented in the resident's medical record. Fair?
Yes.
Changes in the resident's medical, physical, or mental condition should be documented in the resident's medical record. Fair?
It's true.
I'm going to hand you Exhibit 8, which are the progress notes in this case. Here's your copy.
No, thanks.
Sorry.
I thought we previously marked 8.
Oh.
We have 8 and 9.
Oh, I didn't put them right side up. That's my fault.
Just say,
hand me that
we need to
back.
Remark that.
I'm gonna remark it if you don't mind, just so we don't get confused. Actually, can I swap with you?
Yeah.
If this doesn't come off? Thank you.
Sure.
So I'm going 10.
Right.
Alright, and you exhibit 10. Let me do a slightly used 10. Do you recognize exhibit 10 as progress notes for Jennings Fleenor from Riverview Nursing Home?
Yes.
Uh, I want to ask you about a few specifics. On March 27 of 16, which is, if you look at the bottom, the Riverview NH number, it's 180, page 180. You have a note on, towards the bottom there, the March 27, 2016. Do you see that?
Yes.
And did you review that in preparation for your deposition today? This particular
Yes,
note?
this was part of the notes I read.
Can you read the note to us, please?
Sure. To assist with bathing, right, aka scar healed,
What's AKA?
above the knee amputation.
Okay.
Lotion applied to dry skin, Perigard applied with incontinence care, pressure reducing mattress to bed.
Okay, can you explain what you're communicating in this note to people who aren't medical folks?
Sure. Every morning, Mr. Fleener received to be washed up and dressed in bed. Sometimes that took 2 assists, sometimes it took 1. To assist, especially with turning and dressing somebody, it took a lot of turning back and forth in bed. This was his daily routine, and that's what I chart on my shift.
Okay. What was the point of having 2 people assist with getting Mr. Fleenor clean in bed?
Clean and dressed. There's a lot of turning involved, back and forth to dress and wash someone, and then when he was transferred with like a sling Hoyer lift that took to assist, and you have to put the sling underneath, and that was more rolling back and forth, and it's easier on the resident sometimes and the staff if there's 2 of them.
Okay, is one reason for that to help prevent the resident from falling out the other side of the bed?
No,
So fall prevention is not one reason to have a 2-person assist with turning someone in bed?
well, that's not related, but you could if you need to, yes.
Okay. Do you know when Mr. Fleener got a pressure reducing mattress?
Everybody in the nursing home has a pressure reducing mattress on their bed
So why do you note it?
because it's care provided.
Okay. So are you noting that in everyone's chart all the time, or was there something specific about this time? I'm just trying to
No.
figure out.
Everybody's.
There is pretty significant charting, every day, two or more times a day. There are notes here of care being provided. Is that frequency of documentation of care something that is important to residents, either to their care or safety?
What do you mean?
I mean, is there any significance to the frequency of the charting here? That it looks like every time you're on shift, you're putting on a note, other people are putting on notes at least once a shift. as to kind of the care for that day? Is that part of your regular care for a resident?
Depending on the residents. Not every resident, some residents are skilled, they get notes daily. It depends on the resident and where they're at with theirs. Sometimes we're doing, a care conference is coming up, and then we have special charting we provide in preparation for the care conference coming up, so that the, people in the care conference are more familiar with how the resident is.
Do you know what the situation was for Jennings Fleenor that during March of 2016 we see this level of charting?
No,
How would you figure that out? Where would you look, or what would you check to see?
I don't know. I'm sorry.
We're gonna turn to your notes towards the end of Jennings' life in just a moment. Were there, obviously there's a lot of notes over a period of time, were there any specific notes that you thought would be important to address other than what we've already looked at and then the ones towards the end of his life? Was there anything you thought you found important in your review?
No, all my references for washing and bathing were done in bed for Mr. Fleener. We did not do his shower on my shift. That was a evening shift.
Do you know why he was getting showers in the evening?
Every room has a general assignment for showers. Sometimes residents request certain evening showers or morning showers, and so a schedule is made because we can't shower all 30 residents on the same day. So a schedule is made and the showers are divvied up.
Okay. Do you know if Mr. Fleenor had a particular preference?
No, I don't remember that.
Where would you look to see that? Or how would you figure that out?
I don't think you can. Usually it's a verbal request and it's honored by the staff. We just change the schedule.
Okay. So on August 4th, on the very first page of Exhibit 10, it looks like actually let's back up. To the second page there, page 177. There's a note on 729 that involving Jennings' fall during a shower. You see that note?
Is it on the back of the first page?
Yeah.
I'm sorry. Here.
The timestamp's on the first page, but the note's at the very top of the second page there.
Okay, yes, I see it.
Christy Norwalk's note there.
Mm-hmm.
Do you know Christy Norwalk?
Yes, she's a nurse at the nursing home.
And she's an RN, it looks like. Would she have been sorry, I'm blanking on what you call them. Building supervisor or nursing supervisor as an RN, or floor nurses can be RNs as well?
Floor nurses can be RNs as well.
Do you know which it was for her in July of 2016?
No. I think she was probably a floor nurse if she did the nurse's notes, but you have to check with, I can't answer that completely.
Okay. And then the next note, at least in the progress notes, is Robin Phillips. Next is in back to the from August 4th. She is at 6:24, noting 6:24 in the morning, noting the vital signs she's taking because the resident is diaphoretic. Am I saying that right?
Mm-hmm.
What does that mean?
It means sweaty.
Okay. And then your note is at 6:30. When would your shift be starting that day?
My shift starts at 6 a.m., during which we have report nurse to nurse.
Okay.
Generally lasts about 30 minutes, and then I hit the floor.
So the fact that Robin Phillips is noting at 6:24, something that happened at 5:10, it would actually have been on her shift, and now after her shift, she's catching up on her charting.
Correct.
Okay. Do you recall that report? Do you recall any conversation with her that day?
No, I don't recall that report specifically.
Your note is at 6:30. Can you read that note for us?
Resident non-responsive to verbal and physical stimuli.
Let's stop there for 1 second. What does that mean?
It means he wouldn't answer me, and if I squeezed his hand, he didn't squeeze it back. If I shook him, he didn't open his eyes. He wasn't responding verbally to me.
Okay, great. Thank you. Sorry, keep going.
Respirations 44, pulse 128, temperature 96.4 axillary. Blood pressure 104 over 67. Pulse ox was 83% on room air. Color pale, diaphoretic, bilateral lower extremities modeled up to hip.
Can you explain what you were observing for the bilateral lower extremities modeled up to hip?
Bluing, turning blue.
Okay.
Oxygen per nasal cannula applied. Family updated on change in condition. Nursing supervisor updated.
The family updated on change in condition. What did that involve?
It involves a phone call.
Did you speak with anybody?
If I wrote that they were updated, I did.
Do you recall speaking with anybody?
No. But I would have documented message left to call back.
Nursing supervisor updated. Who would that have been?
I don't remember.
Would it be the supervisor type role, the building nursing supervisor?
The building supervisor that day would come and respond and help me.
Okay. What do you recall any of that interaction or anything? Either how you updated him or her, what you told them, whether they came, anything like that?
My nursing supervisors always come when I have something going on and I call. I have something. This was significant change.
Okay.
And they always come to look at the resident themselves.
Do you recall from your memory kind of seeing him and what he looked like at that point? So we have what you wrote down at the time, right? Do you have an independent memory of seeing him there in bed?
No.
Do you have any independent memory of a nursing supervisor coming in or doing anything? I know you anticipate they would have come, obviously, if you asked, but do you recall the specifics? Okay. Do you recall any of the conversation with the family?
No.
When you say family updated, would that be one point of contact, more than one? How does that work?
We're up there. Is the face sheet in here?
I have it here. I'm hitting exhibit 7.
Under contacts. Under contacts here, emergency contact number 1. Some people have more than one.
Okay.
We call the number 1. If we don't get a hold of number 1, we move on to number 2.
Okay, so from what we see on exhibit 7, obviously this is what it was at that time. You would have called Jason Fleenor at that number, and that would have been it. Correct?
Correct. I'm
Okay.
sorry.
Your next note. Well, so this note, you enter at 6:30. Do you know what time it was that you're actually finding him unresponsive?
6:30.
Okay, so you see this situation, you do this assessment, and document it right away.
Correct.
The next note at 6:45, can you read that for us?
No pulse, no respiration, no blood pressure. Nurse and nurse supervisor at bedside. Family and Dr. Callahan informed, order to release to funeral home obtained.
Okay, so nurse and nurse supervisor at bedside. Is the nurse someone other than you?
No, that would be me.
Got it. any idea who the new nurse supervisor is?
I don't recall.
Family notified or informed.
Correct.
What would that entail?
Another phone call.
Do you recall any of that conversation?
No, I'm sorry.
What would you have said at that point?
Well, the first phone call, generally, you tell them their condition. And then the second phone call, you have to tell them that their father died.
Okay.
You have to be honest. It's not an easy phone call to make.
Dr. Callahan informed. What would you have communicated to Dr. Callahan?
That he had passed away and what time. And then he gives me orders that if I can release the body to the funeral home.
Okay, so order to release to funeral home obtained is you're getting that from Dr. Callahan.
Correct.
It's a verbal order over the phone at that point.
Correct.
What do you do with that? In terms of, so you've got that information from the doctor at that point. What happens next in terms of fulfilling that order?
Well, we find out the name of the funeral home that the family is planning on using. And then a phone call is made to the funeral home and they respond by coming to collect my resident.
Okay. Do you recall any of that conversation with the family or any of that situation in this case?
I don't recall. Some people have it already decided on their face sheet.
I'll tell you what, I'll just hand you the face sheet since
Thank
you
you.
know it better than I do.
I don't see that they've chosen one.
Okay. And you don't have any independent memory of that conversation?
No, but that would have been decided by the family.
Do you recall any of the rest of that process playing out, independent memory-wise? Do you recall contacting the funeral home? Do you recall them coming in, anything like that?
No.
What, if any, information is requested of you in terms of, I know there's these notes here, but is there any effort by the facility to gather information about what may have happened to lead to his death?
I am not aware.
Were you asked to meet with or talk with any supervisors, director of nursing, administrator, anything like that?
Not that I recall.
Were you asked to provide, did Dr. Callahan ask you to provide information in terms of beyond, obviously, that he's not, has no pulse and seems to have passed? Did he ask you for information about the medical course over the last week? Did he ask you about other things going on with the patient?
I don't recall.
What would the normal, if there is one, what would the normal course of that conversation be?
Well, you're right, there is no normal course of that conversation. Doctors are usually aware of their residents' condition and their diagnoses.
Okay. Do you know what, if any, information was provided to Dr. Callahan prior to completion of the death certificate?
No, I don't.
Is there anything about, your last note there obviously identifies the funeral home and the family visited and removed the belongings. Do you recall that, the family coming in?
No, I don't recall that.
Anything about the circumstances here on the 4th that you recall beyond what's in the notes?
No.
You also were doing some of the neuro checks for Fleenor, Jennings Fleenor. Do you recall well, let me ask you, what's the purpose of those neuro checks?
To monitor and look for change.
Why?
Because we're monitoring somebody because of something that happened, like a fall, and we want to watch for changes in case they were injured. That's, you look for neuro checks. It's not just vital signs, it's hand grafts and pupil checks.
And what are you, I mean, what is the purpose of doing all that?
We're looking for changes
Why?
to report to the doctor.
And what's the risk that you're hoping to avoid or identify?
I don't know any risk that you would avoid.
Well-
We're monitoring their condition to see if there's any change so that we can identify that to the doctor.
And that could include delayed onset of a brain bleed, for example, if someone hits their head. Correct? So you have to say.
Yes, I'm sorry.
It's okay. Let's take a quick break, and I'm gonna see if I can get you out of here. Okay, let's go back on the record. You'd indicated you had looked at your neuro checks.
Correct.
What did you go in the electronic system to do that? Did you look at
I
paper
went into the
records?
electronic system. I went
Okay.
into the computer and looked at them.
Okay. Neuro checks are done when, well, you tell me, when are neuro checks initiated in a facility?
They can be initiated for any reason. If I look at somebody and I think they don't look right, I can initiate a whole routine of neuro checks to monitor if I think there's something changing with them. If there's an incident that happens, we start to monitor them for any signs or symptoms of things that are changing. It's a good monitoring system for changes that are happening that we can't see visually all the
Okay.
time.
Neuro checks are initiated as part of the fall response, correct? At least at
Yes.
Riverview.
Yes,
And there's a post-fall 72-hour check sheet.
correct.
And those, appreciate neuro checks, I guess, could be for other reasons than falls, but the post-fall check sheet is initiated just when there's falls, correct?
Correct.
How many falls did Jennings Fleenor have at Riverview?
I don't recall.
When you looked at your neuro checks, were those limited to the ones after the July 2016 fall?
Yes, I did not go back through his entire chart.
I'm gonna try to just give those to you. See if I did this right. On 11? And your deposition exhibit 11. And I'll get you a copy too. Hold on.
You keep that one,
Okay, sorry.
and then give it to the court reporter when you're done.
Oh, I'm sorry. Was
So-
I supposed to do that before?
Well, it's okay.
No, you're fine.
Yeah.
Just,
Okay.
what's the page number at the bottom of that?
1038.
Okay. And can you explain what you were looking at?
Neurocheck sheet.
Thank you.
1, 2, 3, 4, 11 of them.
Do you know which ones you did?
I don't see my name on it. No,
would-
I can't tell.
Okay. You would have been day shift at this point, right?
Yes,
Do you remember which, just from looking at earlier, do you remember which days you were looking at?
no,
Okay.
I'm sorry.
That's not your fault. doesn't look like there's any narrative or comments on any of it.
No, there's not a, no.
Is there any place to put any kind of narrative?
No, you would put that on your nurse's notes.
Okay. We don't have any nurses' notes between the fall and your note. Well, I take that back. There's the note from 5 a.m. right before your note. Do you know any other source of information that, or where you would have put any documentation of your nursing care other than nursing notes?
You mean like a nursing note?
Or any reason why you wouldn't have been documenting in the nursing notes over that time?
No. There was nothing to document, maybe. If these are looking good, you don't always put a note in.
Okay. Oh, over here's better. Then if I have to show it to you again.
Oh.
Thanks. Is there anything you think would be important for us or the jury to know about in this case that we haven't asked you about?
No.
Okay, that's all I have for you.
Thank you.
Thank you. Where's your signature?
Thank you for taking my notes. I hope I didn't
Oh, you're great. You're fine.
bad my